Well, hello, everyone. My name is David Mercer. I am a professor of surgery at the University of Nebraska, and I've been asked to give you a talk on making your surgeon a part of your healthcare team. Now, a little bit about me. By training, I'm a transplant surgeon, but my practice has changed so that really what I do, in addition to transplants, is I spend most of my time looking after patients with very complex GI disorders, functional disorders of the GI tract, short bowel syndrome in children and adults. And this has become sort of my whole life. And I lead a big dedicated team that look after these kinds of patients. And so I was actually very excited to be invited to give this talk because it's something that's very near and dear to my heart. And because most of the patients that I see have already been involved in a number of different healthcare environments and may or may not have had one or a variety of surgeons over time. So the original talk that they gave me was to say, making your surgeon a part of your healthcare team. And that's a fine thing, but I would venture to suggest that for many of you out there, you don't necessarily have a surgeon or you don't know who your surgeon is. And so it can be very difficult even making a surgeon a part of your healthcare team. And so what I would like to focus on is just taking you through, this is all sort of philosophical, just my thoughts about how a surgeon might become involved in your care, what the best way is for you to find someone, and how you can engage in them to have the best sort of experience with that person and really improve your overall care. So this talk can be a little challenging because this is a highly variable audience. There's people with all kinds of different gastrointestinal disorders. And while we know that disorders are very common in the population, if we look at how prevalent, depending on how you define a functional GI disorder, the prevalence is very high. We're talking 10% or more of the population. But I would venture to guess that many of you are feeling very much like this, the black swan in a background of white swans. So you have many things that are very similar to everyone around you. In 99% of the ways, you're just like everyone else. But there's important differences that become very unique to you and that make your own set of circumstances very difficult. This can make it challenging in finding a care team, period, let alone finding a surgeon. I would imagine that many of you have probably discovered by this point that a lot of people can have a hard time understanding what you're going through. If you're fortunate to have more easily understood conditions, for lack of a better term, inflammatory bowel disease, short bowel syndrome, those kinds of things, at least there may be a population of people, or there may be people around you who get a little bit what you're going through. But I think in a lot of cases, there's a lot of misperceptions from everyone in your environment. So people that may not understand you, well, your family. It's not uncommon for, not necessarily your immediate family, because they're normally living it with you and understanding, but it's not uncommon for your extended family to say, oh, I don't understand why she has those symptoms. She should just eat and everything will be okay. Or in my house, we could fatten you up, that wouldn't be a problem. But we all know it's not as easy as that. So your family might not get you, your friends might not get you. They might remember back in a time when it was easier for you to do things and you weren't having the same symptoms you have now, or you're not having the problems you are. And they think, well, why aren't you just like the way you were? Or they may get it. But I think that sometimes there can be just a challenge in understanding why you feel the way that you do. Employers and coworkers, likewise, if you're someone who's able to remain employed, these can be challenging times. If you have doctor visits, if you're traveling, if you have hospitalizations and days when you don't feel well, this can start to create a lot of undercurrents of resentment at work and all these kinds of things that can make life very difficult. And the final group that might not understand you is the entire medical profession. And I don't mean that facetiously. We'll get into this a little more as the talk progresses, but for many of you who are viewing this, you may not have found anyone who truly understands what you're going through or has any knowledge specifically about it. And in the defense of those people, there are things changing in the medical profession that we just genuinely don't understand. So while we know that something is wrong, we've not been able to put our finger onto what exactly that is yet. And again, that's stuff that we'll touch on as we go forward. But all of these things create a big varied audience of people watching this, and their interactions with medical teams are highly variable as a result. Okay, so how might you be involved with a surgeon? Well, there's a million different ways that could be. For some of you, you might be fortunate and you never need to have a surgeon, and that's okay. I mean, in many respects, the best surgery is to never have a surgery, because that means you haven't gotten serious enough that you have to be considering that. But for a big percentage of you, probably at some point you've had some involvement with a surgeon. That could be simply getting an opinion. It could be a minor procedure where the surgeon is really just acting sort of as a technician, like placing a line or taking care of a little scar or something like that. Or it could be much more invasive, including a series of multiple operations. So you may never need a surgeon, period. What a lot of you are going to get is this, which is the surgeon du jour, which just means you've got a care team. Your care team, for many people, I would argue perhaps most of you, your main caregiver is probably a gastroenterologist as it relates to your GI condition. Gastroenterologist or maybe an internist or an interested family doctor. And your interaction with a surgeon might very well just be when it kind of pops up in an emergent situation. You come into the emergency department and inevitably somebody gets a CAT scan because that's what they always do. And maybe it shows a couple of loops of bowel that are a bit dilated. And the next thing you know, they say, oh, this patient could have a bowel obstruction, and you see a surgeon. Well, that can be very useful to you, but that's a little bit different from building a relationship with somebody, which is kind of what I want to talk about as we get through the talk. But it is one way you could be involved. Another good percentage of you may have been referred to a surgeon from your GI caregiver specifically. And this might be somebody who they have a long relationship with, or somebody at their institution who has a specific interest or expertise in your area. But that can be very highly variable across the country as to what that actual expertise is. And it is your right, and I would say your duty, to find out a little bit what that experience is. And we'll touch on that, I think, one or two slides from now. Finally, what I would say is the very best thing, and obviously I'm biased because this is the world I come from, the best involvement you would have with a surgeon is as part of a dedicated multidisciplinary team. Now, that's what we have here, and that's a model that I think should be emulated in selected centers around the country. But what you're saying there is you're not just seeing a surgeon when you need surgery, you're seeing that surgeon right up front so that they're thinking about you and maybe looking at it in a different way from your gastroenterologist. And they're not doing it completely separate, they're doing it together. So one doctor is looking at it and saying, gee, I think it could be A, B, or C. And perhaps I, as a surgeon, look back and say, well, A is not very likely, B is possible, and C is something we can do something about. And there you start to get that interaction between your physicians, your dietitians, your psychologists, your nurse coordinators, all the different team members. That's where, especially if you're dealing with a complex disorder or a rare disorder, in the best of circumstances, that's where you want to get. Let's move on to talk a little bit about how we can potentially identify these kinds of things or find what circumstance is best for us. Well, before I do that, let me tell you a little bit about surgeons. Surgeons in general were usually people who did pretty well in school. They did well to get into medical school. They typically did pretty well in medical school. They were towards the top of their class. Getting into surgical residencies is fairly competitive. So they were already in med school, then they outcompeted most of their compatriots in med school, and they got into a surgical specialty. And then they worked really hard as a resident, and they put in all their hours, and they did all their stuff, and now they're graduated and they're working. And I'd be lying if I said there weren't a ton of people that can carry around a fair bit of ego because, gee, I've always been successful and I've always been the big dog around here. And sometimes that can carry over, and that can actually create negative interactions and negative implications for people. It's not always that way, but I mean, that's just the reality about how people are. But what are some little points about surgeons, I guess, that will color your interaction with them and the way they'll think about you? Well, surgeons like things that they understand. What do they understand? They understand things that are concrete and they're right there in front of them. So we like bowel obstructions that have an obvious cause, a hernia, a lump, an abscess. They're things that are discrete, and you look at them and you go, I know what that is and I know what to do about it. And so, yeah, that engenders confidence, and it makes people think, yeah, this is something I can really help with. Now, the flip to this is surgeons don't necessarily like things they don't understand. And for those of you that are watching this that come from the world of functional gastrointestinal disorders, this is where things can be very difficult when you're trying to interview a surgeon because people don't get very good training in this. It's minimal to zero is the truth. And a lot of the things that have to be thought about are outside of the box. They're not conventional procedures. They're things that people have never been introduced to. So yeah, Dave Mercer in Nebraska might do a ton of enteroplasties. I might do a lot of stuff on patients with poor gastric emptying that have pseudo-obstruction, and I have all kinds of different insights because I've been doing this for a long time. But a lot of people don't do that. And if they can't see something, they can't appreciate a specific finding, well, then they get nervous. They get worried because they think, oh, this isn't really surgical and I don't know what to do. And maybe I'm outside of my comfort zone. So surgeons tend to not like to be in those situations. We like to always feel like, oh, we're the bosses and we're in control. But sometimes the downside to that is you don't like the feeling of not being in control. And I think that can sometimes lead to negative interactions with patients. And I'm often the last surgeon in the line. People have maybe been seen by 8 or 10 other people. And my other colleagues in the country who do what I do are in the same boat. You're usually the person of last resort. So you've had a chance to see how all those other interactions have gone. And I guess that's just something I've picked up over the years. Now, what else will surgeons do? Well, I told you surgeons know a lot of stuff. What they're going to do is they're going to take the breadth of their own knowledge and they're going to try to apply it to you specifically. Now, that could be great, right? That may be what you need. If somebody is, an expert at taking out gallbladders and you have a gallbladder problem, well, that's who you want to be with. But if somebody is an expert at taking out gallbladders, you have some abdominal discomfort and it's really more pukey and it's really more a motility problem. And that's what you're feeling yourself is, oh, I don't know. It doesn't really seem like my gallbladder. But that surgeon is still going to look at you and they're going to say, well, I'm pretty good at taking out gallbladders and there's a chance this could be your gallbladder. So I'm going to apply what I know to your situation. Let's take your gallbladder out. And, maybe you get lucky and that's the thing that helps you. But I must say, in a lot of cases of patients I'm seeing with complex GI disorders, there's been a whole series of operations done, none of which have really had any impact on their symptoms. And why was that? Well, it's because people were doing the operations that they felt comfortable doing and saying, well, I'm pretty good at this. It's probably not going to do harm and maybe it will hurt. Maybe it will help, I should say. And so that's not necessarily a bad thing, but when you're talking to someone new or when you're thinking about what the plan is for you surgically, you have to remember that people are going to apply their own background. And sometimes instead of looking at you and your problem and the totality of what you're dealing with, they're going to try to pigeonhole you into something that they already know and understand. Now, that can work out for you, but sometimes it doesn't. And so it's just something to bear in mind as you're going through the journey and you're talking to people. And my last point is something I talked about just a few minutes ago, which is if you're dealing with functional disorders, unfortunately, most surgeons have very, very little training in this. And so it isn't something that they know a lot about. And they will often, going back up to sort of point 1 and point 2, not be very comfortable in that realm. And it will sometimes really make them reticent to do anything when it could be something that could actually help you. Now, in defense of that approach is if somebody isn't comfortable doing something, the best thing for them to do is not do it. And so sometimes the fact that people are uncomfortable with some of these more complex disorders actually has a little bit of a protective mechanism, whether it's intentional or not. Okay. So here you are. Maybe your main caregiver has said, well, I think it's time you see a surgeon. Or you think yourself, maybe this is something I need to get some help with. Well, how do you find someone who can help you? I'd like to say it's really easy. It would be lovely if you could just Google the city you live in and surgeon who can help me, and boom, up would pop 10 names. But it isn't. It's not that easy. Well, why is that? It can be really tough. Experience in dealing with complex GI disorders can be very hard to find. So if you are, and I hate to say this, if you're the fortunate one, but if you're the fortunate one who has something like inflammatory bowel disease or certain kinds of functional disorders, you may be in an area, a community or a region where you have a good interested colorectal surgeon. That can be excellent. If you find somebody who's got some background in this, they show an interest and it's something that they want to do, that can be very useful to you. But it's not always that easy to find somebody who has that experience, especially if you don't live in a major academic center, if maybe that's a number of hours away and traveling back and forth isn't so easy for you. So what do you do? How do you find somebody? Well, most of you are probably going to have this first interaction by talking to whoever your main GI provider is who's looking after your underlying problem. They may have said to you, gee, we think maybe it's time to see a surgeon, and I want you to go and see Dr. X. Okay, well, there's nothing wrong with that. And if they have a good relationship with Dr. X, that could be a very good thing for you to do. But you probably owe it to yourself to ask them, why do they refer you along to him or her? What is it about her that makes, why are you recommending I go and see her? Why should I go and see him? What is it that they bring to the table? Now, they should give you a valid reason. I think if they just say, well, that's just who I refer to, I think it's okay to push on that. You can push in a non-threatening and non-aggressive way, but you can say, well, do you really think they're the best person for me? Do they have experience in my kind of case? If they don't, would it be better for me to see somebody different? Or maybe that, if their GI provider, your GI provider says, she's very thoughtful and she's going to give you a good opinion whether or not she thinks she's the best possible person for you. Well, that's not a bad choice at all then. It might mean that you have to spend an extra morning of your life talking to somebody who's not going to be your ultimate surgeon. But if they can steer you in the right direction to that right person, then that's time well spent on your part. So where else can you find out if maybe they don't have any suggestions? Well, I would suggest to you that looking at one of the major intestinal failure centers in the country can be a really good place to start. Now, again, I'm from the choir, preaching to the choir sort of thing, because I'm in a major intestinal failure center. So I'm biased. I'm biased because I specialized center that focuses on rare and complex disorders and the most challenging cases is going to be better. And I think that the data would support the idea that specialized centers have better outcomes in difficult disorders. So I think these are places that you can check out. I certainly, I can tell you these, someone can call our center. We can make suggestions for things that are closer regionally. There aren't as many good adult intestinal failure centers in the country as you would think. There are more widespread pediatric centers that have an interest in this. And so I think if you're coming at this from a pediatric perspective or it's your child, you're probably going to be able to find someone that's not terribly far away from you. If you're dealing with functional disorders in children, that's very few and far between. And on the adult side, yeah, there are large swaths of the country that are relatively underserved. I won't go into naming names and listing centers and stuff. It's a small community and we all sort of know each other in the places that we would send our family members. So if at the end of this, I'll provide a contact number and definitely someone who was looking at this and, I'm in the middle of the country in Nebraska, but if you were on the West Coast or the East Coast and you said, gee, it's just not possible for me to travel, I'd be happy to. Our program can easily get you tied into the best people in your region. Now, what's an excellent link into these major groups are exactly what you're attending right now, which are these major patient-focused advocacy groups. Because now what you've done is you've taken an organizational expertise and you've said, we have a collection of patients that have similar problems, and we're kind of in the know with who's doing what around the country. So these, like IFFGD, these are organizations, so you can go to the organization and say, who do you think can help me? Where's the best expertise in this? They may very well steer you to an intestinal failure center, but they may also have contacts, in different non-traditional realms that could help. Social media is a big one, but it's a challenging world. It can be extremely useful and extremely powerful, but it can also be a challenging place and it can be a source of misinformation. So it's very much a buyer beware environment. There is sometimes I think there's merit to if someone says, hey, I want you to go and see Dr. blah, blah, somewhere in a specialized center. And if you happen to be tied into groups and social media, it's not necessarily incorrect before you commit to traveling somewhere or something to say, hey, has anybody gone to this place and seen this doctor? What was your experience? And if you get back a bunch of people that say, yeah, it was really good and I got a really thoughtful opinion, well, then that might be worth your time. Looking at some of the stuff that you'll see online, like health grades, like that stuff is honestly, it's not as useful to you as you would think. I'm no expert in that area, but I know those kinds of things, they're often services that a hospital is paying for. If there's negative reviews, they can actually pay more money to get the negative reviews taken out. And so it's not always that straight little grade that pops up when you Google a name, that's not always going to be very accurate for you. So something to think about. Finally, another site, if you have a very specific disorder, a way that you can kind of track down places that might have extra expertise in what you have is to look at what clinical trials are going on in your area. So if you have gastroparesis and you want to find out who's doing clinical trials on gastroparesis, you can go there and you can see, okay, what are the participating centers in some of these trials? And the odds are if somebody's participating in a clinical trial, they probably have established expertise in that area. So again, these can all be ways to help you find somebody who can help you. Okay, how do you make the most of these interactions? So maybe you found someone, you can make the travel, you've got an appointment set up. So what do? A lot of this stuff is not rocket scientist that I'm going to say, but if you're going to go and you have 45 minutes to spend with this person, you'd want to prepare in advance, and they should probably prepare in advance as well. I mean, and I think somebody who's really focused on this would try to do this. So what does this mean? Well, this can require some legwork on your part. If that surgeon doesn't have a big team who's chasing down records and stuff like that, you may need to do some of this yourself. But I think it is pretty important if you can bring along your notes from your previous operations. You can always, every time you finish a hospitalization, I would urge you to get a copy of all of the really critical stuff, your key radiology, your operative reports, a discharge summary, stick that in a binder and have it with you. So if you can provide operative notes from your important major operations, if you've had 30 different central lines, nobody needs to see 29 different central line operative reports. But if you had a big enteroplasty or you had a reversal of a gastric bypass after a volvulus, those are important things to see. So I think bringing your notes along with you is important, and getting them in advance to that surgeon and their office so they can review them. I think to the best extent that you can, it's important to know your own anatomy. People sometimes are afraid to ask questions about what did you do? Draw me a picture. Tell me exactly what I have. But you're your best advocate. You got to stand up for yourself, and you should, to the best of your abilities, you should know your own anatomy. That can even mean going back to people who've operated on you in the past and saying, explain to me. Gee, I haven't seen you for 6 months, but can you just draw me a picture? Can you tell me what's left on the inside? How am I set up? What have you done? That way, when you're sitting down with a new surgeon, you can have an intelligent conversation with them. And finally, this is a simple one that all patients in this day and age, I would hope would know, which is spend some time thinking in advance. What do you want to get out of this? And write your questions down. And nobody should be offended to sit down and go through a question list with you. Anybody who is, that's touch on this in a couple of slides with how do you get the feeling if this is the right person or not. But if you having written questions is a problem for people, that might be a little red flag for you. It might be something you have to think about. Okay. So now you've gone in and you've had your visit with a surgeon, and I'm not going to take you through that because those go in a million different directions, and there's no way I could direct what your conversation should be like. But what I can give you is insight into how I think you should feel when everything is done. Because I think this is a very, very important part of your first interaction with a surgeon, or of any interaction after that. How do I think you should feel? I think at the end of that visit, you should feel comfortable. You should feel comfortable with that person. You shouldn't have a weird feeling. You should feel like they've got my best interests in heart, that they're going to look after me when the chips are down. So I think feeling comfortable, and I think feeling that you were heard, is also a really important thing. Because, sometimes you can go in there and you can talk all about your symptoms, and at the end, what gets presented back to you is a plan that doesn't seem to relate to what you actually said. And if that happens, I guess I would say either there's been a breakdown in communication and you need to have another whole appointment to go over it again, or they're just not listening to what you're saying. And if you're going to go on a journey with somebody that might involve having your body cut open and going through a surgery, I think you want to feel both comfortable with that person's intentions, but you also want to feel like they're genuinely listening to what you have to say. I think that everyone should understand by the end of a visit what is going to happen to them, or what is the plan going forward. That's a big mantra for us around our program. Is I tell every patient that at the end of the visit, you should understand everything that we've talked about and what the plan is going forward. And if you don't understand it, then you need to say something, but our visit isn't over until you understand it. So if we've not conveyed that to you, then somehow we're not finished. We just have to take more time, and we have to make sure that everybody is on the same page. because this isn't easy. Some of these things are really, really tough. And if we're not all on the same page, we're not going to be successful, especially in some of the more challenging disorders. Finally, this may apply to you, but is how does that surgeon fit into the context of your care team? In some cases, this might not matter so much. Maybe they're just going to put in a Broviac catheter and it's a simple little technical procedure and they feel good doing it. And then you don't have to worry because they're not necessarily going to have a ton of input. But if you've got a problem that requires periodic interventions or it requires a surgical thought, then you want to know, how's this person going to fit in? Does it strike me that they're a decent communicator? Do they have a good relationship with my main doctor? Are they maybe my main doctor? So for me in our program, I mean, I'm driving a lot of the care. I'm driving what is happening because it's me, and I have a team of gastroenterologists and nurses and dietitians. So I'd like to think that we're all co-equals amongst everyone on the team, but we're all intimately right in the center of the battle together. So I fit in as a surgeon in the dead center of things, along with my dietitians, along with my nurse coordinators, my physician assistant, gastroenterologist. We're all right in the center of things. You need to know how that is for you and what your individual circumstances. Okay, here are a little advice on don'ts. These are just a few things, again, over the years, if you're starting a new relationship with a surgeon, maybe it's somebody you've seen for the first time or the first couple of times, or maybe they looked after you in the hospital in an emergent basis for the first time, and now you're seeing them sort of electively in clinic. Well, what are some of the don'ts? Resist the temptation to tell them that every previous surgeon that you've seen was an idiot, and here's the 10 reasons why. Some of them may have been idiots. I'm not denying. There could be people that didn't do a good job for you. But to the extent that it is possible, resist the temptation, because any surgeon worth their salt, if you come in and you say, I've seen 10 different surgeons and every one of them is an idiot, if I'm the 11th person, I'm just figuring I'm probably the next idiot in line. And so that's going to right away create a little bit of an invisible emotional barrier, because that surgeon's going to go, oh, okay, you had conflicts now with the previous 10 people, and now you're coming to see me and you're telling me that I'm wonderful, but why am I going to be any different from the others? So even if that's been your impression, that's the kind of information, those kinds of judgments can come out as your relationship evolves, but that doesn't necessarily need to be an upfront thing. Don't come in the door insisting on surgery. Okay, I respect that everyone knows their own body and you know your symptoms, but you're not the expert in what needs to be done. You're going to seek the advice of an expert, and together you're going to work through risks and benefits and decide on what to do. So if a patient walks through the door to me and in the first 2 minutes they tell me I'm here because I want this surgery and I want this, this, and this, I can tell you right away that's the kind of conversation I shut down immediately. Because I tell them, look, if you just want a technician, go somewhere else, because that's not here. Now, if you want me to listen to you and think and give you my opinion, that's what you're here for. And that's what I'll do. If it involves surgery, great. I have a ton of people come through everyone thinks they're coming to get a surgery and that surgery is going to just be miraculous and everything's going to be better. And we spend a lot of time talking about how surgery is a part of things, but it's not necessarily the answer. And it can take you down a pathway that can be a challenging one. So you're not there to insist on a surgery. You're not there to tell that surgeon what to do. You're there to convey how you feel, what your symptoms are, what's been done, what's worked, what hasn't worked. You can have a bias towards surgery. You can say, gee, I wonder, I've tried everything and nothing has worked, and I wonder if I'm surgery. That's okay. That's all right. But what this surgeon should be doing for you is thinking about you and giving you their opinion about where they fit in. Don't be unrealistic in your expectations. So if you have had 15 years of abdominal pain, and that abdominal pain has led you down a path where you have to take pain medication to get through the day, I don't deny that to you. That if that's what you need and it allows you to be functional, it allows you to have some quality of life, who am I to say that that's wrong? But don't walk through the door thinking that if you've had pain for 10 years, that me or the next surgeon or whoever else it's going to be is going to do a magical operation and they're going to take down the adhesions and the angels are going to sing and everything's perfect and you have no more pain and ride off into the sunset, because that's not realistic for you. And a surgeon who's worth their salt should say, that's not a realistic expectation. These are the things you need to work towards. These are the goals. This is what you can expect. So don't be unrealistic in your own expectations when you come to meet someone. And finally, just a very practical piece of advice, don't ask for pain meds at your first visit. Okay, I understand many people might genuinely have a need for analgesia. There's lots and lots of different ways to do that. But just, I can tell you as a surgeon, if it's your first interaction with the patient, they come in and they get your opinion and everything else. And then at the end they say, oh, doc, just one more thing. Hey, I'm out of my oxy prescription. And is there any way that you can just get me, I'm not going to see my own doctor for 2 weeks. Is there any way you can just get me some Roxy for the next 2 weeks or something? I mean, I'm going to say no. And most people are probably going to say no, but it's also going to set up a red flag. And that's not to say, oh, you're a drug seeker and oh, you're faking it and everything else. But this is just a little bit of common sense and a common sense advice to you as a patient, which is, you know, you may genuinely, your need might be good, but you have established caregivers. If you've just met someone, think about this is like a first date and you don't want to ask for so much, and so I think that's just some practical advice is be a little careful about that. So let me wrap up with just a few thoughts, and this will sort of be my last slide. Surgery is intimate. So something that I teach all of my students and all of my residents is of all of the different relationships you're going to have in life, arguably your relationship with your surgeon is one of the, not the most intimate relationships. Why is that? Well, because as a patient, you say, let's sit down and let's talk about me. And then you say, now I want you to make me unconscious, put me to sleep so that I can't defend myself. I can't have any input. And then I want you to cut me open, go inside my body and do what you think is right to make me feel better. And I would argue to you, as I teach to all my trainees, that's about as intimate and trusting as any relationship can be. I think that should be treated very reverently by a patient, but also by a surgeon. I think both parties have to respect this isn't just a little thing, it's a big deal. Every surgery is a big deal. No surgery should be undertaken lightly. Surgery can be dangerous. We often talk in surgery, we go to lectures all the time at our conferences with titles like, is it possible to give informed consent? What do we mean by this? Well, we naturally as human beings assume a positive outcome. And we really do. And it's very difficult to convey risk appropriately to people. So someone can say to you, there is a 30% chance that you're going to have a leak and you're going to develop a fistula from this surgery. But the brain grabs onto the fact that, oh, well, there's a 70% chance everything is going to go great. And you naturally assume you're part of that 70%. That's just how the human mind works. And it's important to sit back sometimes and think, stuff doesn't always go the way I want it to go. And I often, when I'm talking with patients and I'm laying out different courses of action and risks and benefits, I'll say, we have to both be comfortable in our heart that if we go down this pathway over here, which is a pathway of complications and problems, that in our heart, we're comfortable going down that path. If we are, that means we've made the right decision. It means that you as a patient have said, I'm suffering enough. I need this. It's going to improve my quality of life so much that I'm prepared to take that risk, even if it's 1% or 1 in 1,000. I'm prepared to take that chance that I could have a negative outcome. Now, what you would hope is you have a good, intimate relationship with your surgeon, and that surgeon says, if we go down that path, I'll be with you and I won't abandon you. And we'll get through it together. And if it means we have to go back and we have to do other things, you will be well someday. I think that's important. Surgery is a journey. Rarely is a surgery a one-off. Just boop, you fix something and everything is perfect. When it happens, that's awesome. You feel great, we feel great, we each part ways and everything is perfect. But often that isn't the case, especially in complex GI disorders. Your surgery is a journey. So what you're trying to do is build a care team and a relationship with someone who's going to be with you and hold your hand in that journey and stay with you through the good times and the bad times. And that might require thinking differently about things. Doing surgery when a surgeon might not be comfortable. Different kinds of approaches. I think it's important to recognize that it's more than just a one-off interaction, or it should be if you really want the best outcome. And the very final point, something that you all know but can't be stressed enough, which is you are your best advocate. So your care team is going to look after you. Everyone else is going to look after you. But in the end, ultimately, you are the person who makes the decision about who you're going to trust, what you're going to do, and how it's going to be done to you. They're going to look after the details. They're going to give you their expert opinion, but your heart has to feel good about the process. That's why I think the most important thing you get out of your interaction with a surgeon is, how do you feel at the end of that interaction? Do you feel like this is someone I can go to war with? And if it is, then you found a good person, and they're going to take you on a good path. So remember that it's the steps that you take. It's your pre-preparation. It's standing up and advocating for yourself. Those are the things that are going to get you through the best. That's all I have for you. This is my contact information and a phone number that you can call. And as I said, we're in the center of the country. We're happy to help with providing any direct care to anybody who needs it. But at the same time, we equally, I'm tied into, the clinical trials scene and everybody who's in the major centers. You can give us a call. My team are all experts, and they would link you up with somebody regionally if that's what you needed. Thank you very much for taking the time to listen, and I hope everyone has a really good time at the Advocacy Summit.